thank you for joining. Oh, we have a recording in progress. Have to deal with that. Thank you so much for joining us for this conversation. I am Melissa Goodman. I'm the Executive Director of the Center on Reproductive Health Law and Policy at UCLA Law School. We are, for folks who don't know us, an independently funded think tank and research center where we're developing long-term, lasting solutions that advance reproductive justice and address the current national crisis in abortion access. And in the past year, we've done a lot of research and convening and solutions generation work on pharmacies as an access point for reproductive health care. And pharmacies really are a vital and growing opportunity as a direct access point for hormonal contraception without needing another provider or an appointment or other barrier involved. And frankly, we may see pharmacies only grow in importance depending on legal changes with the new federal administration and embolden states carrying out a new slew of negative policy innovations to restrict access to reproductive health care here in the US. On a happier note, over-the-counter access is now a reality with Opill, the first over-the-counter birth control pill, which is exciting, but it's new, and there are still some significant issues with public awareness, coverage, affordability. We'll be talking about that today. Now, and then on top of over-the-counter, we have direct prescription by pharmacists, which is available and allowed in 29 states, but implementation and public awareness has had challenges rather universally. And here at the center, we've now conducted a number of studies about access barriers at pharmacies. We've also held a nationwide convening with government officials, pharmacy chain executives, insurance companies, pharmacy board officials, pharmacists, and advocates, which was funded generously by Arnold Ventures. And through all of this work, we've found that demand for these services, which is really tied to public awareness that these services exist, is really a key implementation challenge, but also an opportunity. So one other thing I'll note before diving into this, our speakers in this conversation is in our own research, we've also found particular access issues for young people for hormonal and emergency contraception, even though there's not supposed to be an age restriction. And our California-based research excitingly spurred really important actions by the governor, the attorney general, and the Board of Pharmacy in California to address some of the barriers that we found, including having them put out an alert to consumers about the availability of pharmacist-prescribed contraception and their rights, which may be an interesting model for other states. But today, that will be the most you hear from me. You'll be hearing from experts who have been deeply involved in increasing access to access in pharmacies and specifically raising awareness. And though much of our work at the center has been focused on pharmacist-prescribed contraception, we're highlighting that together with over-the-counter access because the Opill momentum really does provide an opportunity to expand both avenues of access. So with that, very briefly going to introduce our speakers and then we'll dive in. Today, we have with us Victoria Nichols, who is the project director of Free the Pill at IBIS Reproductive Health. Victoria led the very successful coalition-driven campaign to make the first birth control pill, Opill, available over the counter in the US. Yay. Mollie Ashe Scott is also with us. Mollie is a regional associate dean at the UNC School of Pharmacy and has been instrumental in implementing pharmacy access to contraceptives in North Carolina. With her is Jill Sergison, who is the co-founder of Points True North Consulting. And Jill played a really pivotal role working on policy, coalition building, and program implementation of pharmacist-prescribed contraception in North Carolina alongside Mollie. And then finally, and excitingly, we have Louise Brown, who is a professor of pharmacy education at University College London School of Pharmacy. And Louise has worked to educate pharmacy students and the pharmacy workforce about novel models of contraceptive access in UK pharmacies and the expanded role of pharmacists as prescribers. So we're excited for this conversation. You have incredible experts here, and we're going to dive right in. Each speaker is going to give a shortish presentation, 8 to 10 minutes, and then I will have some questions, and then we will try our best to leave time for questions from the audience. I cannot promise we will get there in the short hour we have, but if you do have questions, please do put them in the Q&A function. And with that, I'm going to throw it over to you, Victoria.
Thanks so much, Melissa. Hello, everyone. It's really great to be with you and to join this really fantastic group of experts to talk about one of my favorite topics, expanding access to contraception through pharmacies. And thank you so much, Melissa, for that introduction. I would like to just start by sharing a little bit of history around Free the Pill, the effort to bring the first ever birth control pill over the counter in the US, and what it took to get there. And then I'm happy to share a little bit about, now that we have Opill on the shelves, what are the challenges and the opportunities, of course, for expanding access and making sure everybody knows about it. So the Free the Pill Coalition started as the Oral Contraceptives Over-the-Counter Working Group, and it started back in 2004. And so this coalition has been working for nearly 2 decades to achieve what we call a movement-driven win, because it truly took a movement and coalition to get here, to get to the FDA approval, which happened in 2023. Obviously, this work didn't happen overnight. It took research, advocacy, and probably most importantly, principled partnerships to get to this moment. And we have lots of resources on our website that tells you more about the history of how we got here, but I'll just highlight 3 really important things. One is just building a really robust coalition. So we built a coalition. We're now 250 plus members, but it's really rooted in reproductive justice principles and youth adult partnerships. So the coalition was trained by a reproductive justice organization called Sister Reach that really helped ground us in the needs and leadership of the communities that we needed to be focusing on, and particularly ensuring that this switch was going to serve communities that experience systemic inequities due to systemic barriers to care, other forms of oppression, racism, et cetera. And we also got trained in youth adult partnerships by an organization called Advocates for Youth, which runs a Free the Pill Youth Council. And you talked earlier, Melissa, about the unique barriers that young people face. And so we wanted to make sure that Opill didn't have an age restriction and that we really centered the needs and experiences of young people throughout this entire process. We, of course, also work with researchers, medical associations, providers, including pharmacists, to really ensure that the data was strong and that we had strong clinical messengers for this work as well. The coalition did start with focusing on a progestin-only pill, which is what Opill is. We knew that POPs have fewer contraindications, so they'd be accessible to the widest range of people. Also, Plan B is progestin-based, so that was a good place to start. But we emphasized that all birth control pills are safe and effective, and so envision a future landscape in the US where we have a combined oral contraceptive and other hormonal methods over the counter. And then lastly, we partnered with pharma. So in order to get a birth control switched for over-the-counter use, you have to go through the Food and Drug Administration, and you have to have a pharma partner to work with you to do that. In 2016, IBIS partnered with HRA Pharma after putting out a wide call to pharmaceutical industry, and HRA Pharma stepped up. HRA Pharma is now Perrigo, and we've been working with them since that moment to really make sure that the application was strong, that it would meet the FDA's criteria, and that we could get it approved in the US. And so flash forward to now, we have Opill on the shelves. Again, it's a progestin-only pill. It's over the counter. I hope that you are all seeing it in your pharmacies and on the shelves, which is really great. Opill is in about 35,000 stores nationwide, in all states, in major drug chains. And we did a fun scavenger hunt and can't tell you how excited our team was to see it on the shelves when it was first launched. There are a couple of things that may hinder access for people in pharmacies. One is cost. So Opill, although it is, fantastic to have it on the shelves, we know that the cost may be too high for people, which is why things like insurance coverage are so important. And I'll talk a little bit more about that later. The other thing is consumer awareness, and we know that KFF did this really great survey, their 2024 Women's Health Survey that they released in September, that provides some helpful data on what awareness is for Opill. And that survey found that just about a quarter of women in their survey, 18 to 49, said that they had heard about a new daily oral contraceptive pill. And due to systemic inequities, we typically see that for Black women, Hispanic women, people of color, those numbers are even lower. So there's equity challenges there. And then, the other piece is insurance coverage. So this is, I think, one of the really complicated topics, just because our healthcare system has a really complicated health insurance system. We have, federal coverage, we have state coverage, we have lots of different elements of the system interacting, private, public. There are 10 states with OTC coverage policies for contraception. We have a great chart that outlines the state, and we love updating that chart, by the way. So if there's a state that wants to pass a policy, please let us know, and we work directly with state advocates to support with technical assistance and help convene them to share lessons learned. And then under the Affordable Care Act, contraception is covered, which is great and has been a tremendous benefit. However, insurance plans can and often do require a prescription for that coverage. So when it comes to an over-the-counter oral contraceptive like Opill, getting a prescription to then get it covered when it's right on the shelf becomes really challenging. So there's lots of solutions for this that we outline in the implementation report. But a couple of things that I'll highlight here are the need for the need for clear guidance for pharmacists. So pharmacists are great. They are a great point of access, but when it comes to processing claims for over-the-counter insurance coverage, the system is really designed for prescription products. So we, in the implementation report, outlined some really clear solutions, like providing guidance on what to put into a field that's called the NPI number, where pharmacists are supposed to indicate who's prescribing this. And for an OTC product, there's no prescriber because it's not supposed to be prescribed. So providing clear guidance on how to do that, how to process claims for an over-the-counter product is really important. CVS Caremark did that. Right when Opill was launched, they put out guidance for all their pharmacies, which was really helpful, and looking for other PBMs to do that, insurance plans to do that will be really helpful. The other piece is state, just the market segmentation that state advocates and state policies have to kind of grapple with. The state plans or state law only regulates certain types of plans. And so it makes it really complicated, not only for states to implement their policies, but also to communicate about their policies. I'm just putting out a scenario out. You're in a state that has OTC coverage and you want to get coverage for that, but you're not sure whether your plan is under a state law or federal law. So that's something that really needs to be figured out and worked out, and communicating, making sure that enrollees have clear information on what type of plan they have is really important. And then the last thing that I'll just comment on is just consumer education and awareness, which is so critical and so important. Things like signage in pharmacies to tell you, hey, Opill's on this shelf in this aisle. But beyond that, how do we make sure that consumers know about insurance coverage, know how to, get insurance coverage for over-the-counter contraception if they need it, and then also thinking about other things like cost assistance. Opill has a great cost assistance program that's you can find at opillcap.com. But how do you make sure that people in pharmacies know about discounts, know about how to get product for free if they need it, those types of things, to make sure that that information is accessible, youth friendly, in multiple languages, that the resources are really needed to support those efforts. So really excited to not only have this conversation today, but also to hear from other people on the panel. I know lots of really great work is happening in the pharmacist prescribing space, and there's lots of partnerships I think that can happen, public-private partnerships, partnerships with community-based organizations, and really learning from pharmacists' experience as well as consumer experience to make this as easy as possible for people to get their contraception. So thank you so much.
Thank you so much, Victoria. That was so great and such great work. We're so excited. And I do want to put in I'll say this again at the end, but just so folks know, a lot of those important insurance coverage, payment, how do you get it actually kind of covered in the system are issues we'll talk a little bit about today, but we're going to actually have a separate webinar on May 3rd for folks who are interested in those issues, like diving real deep into that, which is, exciting for some people. Not exciting for others, but I'll plug that at the end. I'm going to turn next to Mollie and hear a bit about the North Carolina experience.
Vic, thank you so much for having me. Forgive my scratchy voice. I'm a little under the weather today, and I want to make sure that you can see my slides. I just have a few to show. Can y'all see that okay?
Yes,
Wonderful.
they're not in slide view yet, though, if you wanted them in that way. So we see them sort of the column to the side, and
Okay.
you might want to hit the from beginning button up there in the left corner.
From beginning. How about now?
Usually takes a second. Yeah. I try it one more time.
Okay.
If not,
I
yeah,
have a couple of screens going at one time, so
it's all good.
let me
We
try
definitely
to...
saw the right screen, so that's actually better than I often do. There we go. Now it looks great.
Excellent. Okay, wonderful. Thank you so much, Melissa. And Victoria, thank you for all of your work and the work that Free the Pill has done to get Opill over the counter. As mentioned, I am Mollie Scott. I'm the Regional Associate Dean at UNC Eshelman School of Pharmacy and have done a lot of work here in North Carolina advocating for pharmacist-prescribed hormonal contraception. And as you may know, pharmacists are considered the most accessible healthcare professional, and most Americans live within 5 miles of a community pharmacy that might be an independent pharmacy, locally owned small business, or a chain pharmacy. And we are doing a lot of different things in public health these days. We were certainly out front immunizing everyone during the pandemic and do a lot of counseling and certainly dispensing and collaborating with primary care offices. So we're very excited for the opportunity to step into the reproductive health space. See if I can get this to move forward for me. There we go. So we passed pharmacist-prescribed hormonal contraception in North Carolina back in 2021. It authorizes immunizing pharmacists to dispense, deliver, and administer certain medications. And so pharmacists in our state can now initiate oral and transdermal combined hormonal contraceptives, prescription progestin-only contraceptives, and we also encourage our pharmacists who are working in reproductive health to ensure that they have emergency contraception on the shelf, that they have Opill on the shelf, that they have information about condoms handy and ready, and that they have opportunities to refer patients who need additional services beyond the scope of the pharmacist to another healthcare professional within the community. So we are several years into this initiative. And it's going very well. One of our goals was to ensure that we had a birth control pharmacist in all 100 counties in North Carolina. So we are a very rural state, and 80 of our 100 counties are considered rural. And so that, of course, means that we have to work a little harder to ensure that patients have access to care and can see a provider to obtain birth control and other healthcare services. So to date, we have a birth control pharmacist now in 93 counties out of 100. So we're seeing uptake, and we're working on scaling this initiative, partnering particularly with Walgreens right now through a grant with my colleague Stephanie Ferrari and the NACDS organization to help scale in chain pharmacies, and working on some implementation science approaches to help support making this mainstream, making this part of the normal workflow of pharmacists, so that just as it is the norm to go and pick up your medications that are dispensed from your pharmacist, get your flu shot, and then also to be an access point for birth control. One of the things that we know in our state is that access to contraception on college and university campuses varies widely. We have 54 institutions of higher learning across North Carolina, and we took a look at the websites several years ago to see what contraceptives were available for college-age women, and we found that contraceptives of any type were offered only on 43% of North Carolina college and university campuses. And full spectrum contraception, including everything from condoms to the pill, the ring, the patch, to long-acting reversible contraceptives, was offered only on 6% of North Carolina college and university campuses. And those ended up being large public institutions. So East Carolina University, North Carolina State University, and the University of North Carolina at Chapel Hill. And so this tells us that pharmacists have the opportunity to serve the college age population, because there's always pharmacies in college towns, whether it's a chain pharmacy or an independent pharmacy, and help close the gap for reproductive health care needs. So this has been a population that's been very important to us because of the negative impact that an unintended pregnancy can have on educational and economic attainment for those who have a uterus who are learning in higher education. So we're doing our best to reach out to colleges and universities across our state and form those partnerships. We also know there are gaps in care in North Carolina in terms of access to emergency contraception. And so we had a research student who recently did a secret shopper study of 140 randomized pharmacies in Tier 1 counties of North Carolina. And those are the most distressed counties, both economically, educationally. They're under-resourced counties across our state. And so we had a script that was prepared, and the student called pharmacies using that script to inquire about emergency contraception availability. And what we found is that 75% of chain pharmacies had availability, whereas only 25% of independent pharmacies had emergency contraception readily available within the next 24 hours for our secret shopper patient to go and obtain emergency contraception. And moreover, independent pharmacies were more likely to keep emergency contraception behind the counter, probably because of concerns of cost or theft. And so we're working very hard to ensure that as we are stepping into pharmacist-prescribed hormonal contraception, that our pharmacists see this reproductive health initiative as a comprehensive initiative that focuses not just on whatever we can prescribe under statewide protocol or standing order, depending upon your state, but also remembering that we want to make sure that Opill is available and that the pharmacists know how to run that claim through so that it can be paid for when that's a possibility for the patient, and that emergency contraception is readily available, and that we're not setting up barriers to access to care for people who need us the most. One of the things we wanted to do in North Carolina a little bit differently with our pharmacist-initiated contraception initiative was to ensure widespread implementation and uptake, and to look at the outcomes of our success. So we were fortunate enough to receive a $705,000 grant from the Duke Endowment to help us achieve those goals. We're currently in year 3 of that grant, and we've done a host of activities to help support pharmacists and communities as we seek to provide patient-centered care and to break down barriers for patients who are seeking contraception, and that we do that in a non-coercive way. So some of the things that we have done have included hosting a contraception summit in Chapel Hill. And we did that back in 2023. And we brought together reproductive health stakeholders with the pharmacy community to talk about how pharmacists can step up to the table and partner with communities and other stakeholders that have been working on improving access to reproductive health and providing equitable care for many years. So at this convening, we had legislators, we had folks from the ACLU, North Carolina Medicaid, North Carolina Department of Health and Human Services. We had a host of different types of pharmacy organizations, including chain pharmacies, independent pharmacies, and representatives from all 4 schools and colleges of pharmacy within North Carolina. And I'm sure I'm leaving someone out. This event was led by our colleagues with Points True North, including Catherine Reed and Jill Sergison, and you're going to hear from Jill in just a bit. Some of the things that came out of this convening that were very important to us was that our pharmacists who were early adopters of pharmacist-prescribed contraception said that a major barrier for implementation in the community setting was reimbursement for services. So pharmacists are historically paid for products and not necessarily for clinical pharmacy services, depending upon the rules and regulations in your state. And this led to an accelerated payment model for the clinical pharmacy services for contraception by North Carolina Medicaid, and also a payment model for Opill for North Carolina Medicaid. And so we were very excited with the partnership that we had with our leaders in DHHS and Medicaid. We think that that really has led to the breaking down of barriers that pharmacists were facing. And we're working with other payers to break down those barriers to ensure that pharmacists are paid for their time, and encouraging other payers to also cover Opill as well as a viable option for patients who are seeking contraception. So things we're doing this year in 2025, we want to continue to increase public awareness, and Jill is going to talk about our marketing campaign so that the public is aware of the work that we're doing. We're working to scale services across the state now that we have a birth control pharmacist in 93 out of 100 counties, and we're particularly focusing on chain pharmacies. We're delighted that Walmart is offering services across our state, and Walgreens is working on a playbook with that NACDS grant that I mentioned earlier. We're also taking an implementation science approach, using that implementation science research framework to understand better how to implement services in community pharmacists so that it can be a part of normal workflow, and that's led by Mel LeBay at the University of North Carolina. And finally, we're looking to see if we have saved money for North Carolina Medicaid, and Casey Tock, who's a colleague at the University of Utah, will be leading a pharmacoeconomic analysis of how this has hopefully positively impacted on the health of women in our state, and how it has impacted positively on access to care and on our North Carolina Medicaid system. So I will stop there.
Excellent. That's so amazing, Mollie. Thank you so much. And we're going to hear a little bit more about that marketing campaign and other aspects of the North Carolina successful campaign from Jill.
Hi, everyone. It's a pleasure to be here. I'm going to try to do what Mollie does, just give you some idea here of, is that all good? Nice.
Looks great.
So I'm Jill Sergison. I'm the co-founder of Points True North Consulting with my partner, Catherine Reed, who was in one of those pictures before. We're a private consulting firm, and I've had the pleasure of working with Mollie for a very long time. I think we were calculating maybe about 5 years now on this work. We first started working with her with just the submission of the legislature. Once that passed and we got funding from the Duke Endowment, we moved into some of our strategic planning and coalition building that made this a success. Mollie spoke to you about the reimbursement model. And so here we are now at marketing. And it feels very thrilling, a little like Victoria seeing her pills on the shelf. It feels just really, really exciting to be at this stage in the game, frankly, way ahead of schedule. So, so happy for all that came before and all of our partners to make that possible. So I wanted to give you a little snapshot of what we've been doing. I'll kind of allude to this. So the marketing campaign is a huge undertaking. And so we first of all wanted to just bring attention in two ways, because it's sort of this catch-22 or chicken and egg. You don't want to advertise it too much initially if the pharmacies aren't ready, and then you don't want to not, you don't want to have the other situation where the pharmacies are ready and they don't have any consumers. And so we were really trying to balance that. And so what we did is we worked with a partner out of Canada, actually, and we were really strategic in the way that we went about with this social media campaign, which launched last fall. What we did first was we did static ads and video. Everything about this was sort of strategic. We have really partnered with DHHS a lot in North Carolina. They have been very helpful to us. And so we wanted to highlight that this is a North Carolina initiative. We intentionally left our branding, or even UNC's branding, off of this so we could give these ads to other people like DHHS and say, without having to redo this, they can add their logo on it if they want. We were also very intentional about not just saying certain types of contraception. We left it open so it could be used for Opill as well, even though that really wasn't part of our remit for this project. And so I don't get these because I'm almost out of the demographic, but of the audience. But I have friends who get them and they send me pictures. And so we are waiting to see on uptake. But right now we know from our performance metrics and that from our agency that's keeping track of all this, that there has been a lot of good uptake and clicks on the link. We were very lucky to work with the North Carolina Association of Pharmacists, NCAP, to develop a pharmacy finder website. So I'm not going to go into a lot of detail. You can go to ncpharmacyfinder.com and you can find a pharmacy in North Carolina. Another place I'm going to talk about a little bit more is sort of outside of what we do, but that's Birth Control Pharmacist that Sally Raffi leads, which is also a very good resource. So one of the first things that we did is we wanted to design a logo specific to North Carolina. And so we hired someone to do this logo, and we had these printed up in all kinds of marketing ways. So we presented a bunch of designs to our advisory committee. We had them vet them, some debate, some talking about what do we want to name this, what do we want them to say. And so these are the things that are available to pharmacists. Again, this is free collateral for them. The goal, of course, is for them to be able to do their own marketing with these things, so they have access to these files. We don't own them, which we thought was really important. And these were distributed in the forms of stickers, button, window clings, the whole thing. And we haven't just given them to pharmacists. I think Mollie's ordered more. She's taken them out. She's given them to consumers. I'm sure I'm going to see them on a water bottle at some point. Our advocates. And so this has been a great way for us to try to build that sort of cognitive bridge between something they might see a logo on social media and then be able to see it in a pharmacy when they go in and be able to make the connection, like, oh yeah, they're trained and they know what they're doing here. So in addition to that, Catherine and I developed welcome packets for these pharmacies when they became credentialed with Medicaid. And so the welcome packets are, they get mailed out through our partners at UNC. And inside, it's sort of a starter packet for marketing. So inside, they have these clings, the stickers, the buttons, everything I just talked about. We also provided them with scripts for social media. Sorry, it says media there. Social media. So if they want to put their something on their website, their LinkedIn, their Instagram, they can do that. Any advertising, there's some language for that. A lot of pharmacies have phone messages when you call. We put scripts for that. And then again, we provided them links to the images. If you're in the process of doing this and this is not something you want to do, the Birth Control Pharmacy website is, and Sally, correct me in the chat if I put pharmacist instead of pharmacy, is a really wonderful national organization that has all of these things available as well, and that you can purchase for a very reasonable fee, and it gets the job done, and really nice stuff there too. We were lucky, like I said, to be able to work with North Carolina DHHS both on the Medicaid side to do the reimbursement model, but also on the family planning side. Catherine and I co-chair the state's family planning group with the Duke Endowment and DHHS, and that has given us a wonderful insight into the opportunities that we have with them. And these were written and put together by a lovely woman there named Avril Edwards, who's actually in charge of their family planning, Medicaid kind of promotional side of things on DHHS. And so what she did was she created these two, they're publicly available as well. I think I gave the links to Kelsey, so this can be dropped in the chat, but these wonderful pamphlets about the available services through pharmacies. And so again, this has been vetted through our advisory committee, which contains people from all walks of government administration, clinical services, both reproductive health specialists, pharmacists, and other experts. And these are just kind of a quick and easy way for consumers to see what the basics are to accessing care. And again, the Pharmacy Finder logo is on there too. I really like what she did with Opill because she gave kind of a nice breakdown. And I'm hoping that's also very, very helpful. Again, everything what we're doing is sort of method agnostic. And so there's a lot of ability to leverage our campaigns with further campaigns. And we really felt like that was and remains a key to a sustainable model. So last, our next steps and opportunities. I put explore funding in the bottom. That should probably been at the top. Marketing is expensive, I think, not only for its depth, but for its breadth. And so we've given a lot of thought about how we can not put our eggs in one basket. And what seems to be very helpful, if you're familiar with North Carolina, is that we have a road, I-40, that runs straight through the state from one end to the other lengthwise. And so everyone travels it. And so if you want to get to the coast or the mountains, you have to look at all the billboards. So we're working with that same firm to do some billboard advertising. They're currently working on an explainer video for us that can go on social media. It can just be used at conferences. It can be used in events like this. And this is all really with the goal that we've heard over and over again from our community engagement exercises, which are to really establish pharmacies as a trusted first-line source of sexual and reproductive health information. It's not that they just happen to do this, but they're experts as well. And this is a trusted, accessible place in most communities for people to go and get sexual and reproductive health care. So that is it. And thank you for allowing me to present today. Feel free to email me directly if you have questions about this, especially if we don't have time to get too many questions at the end. I'm happy to answer about our marketing and about any stage of the project or anything that Mollie talked about as well. So thank you.
Thank you so much, Jill. Those resources and those pamphlets are so great, and there's so many things. I like how adaptable they are, as you were saying. So thank you.
Thank you.
All right, and next we're going to turn to learning from Louise and seeing what kind of lessons about centering pharmacies as contraception access points we can learn from the UK and some of your work there. So thank you.
Thank you so much. I want to say thank you to Melissa for inviting me to join your panel. Inspirational and energizing, the work you're doing. So my name's Louise Brown. I'm a professor of pharmacy education at UCL School of Pharmacy in the UK in London. I was asked to talk to you a bit about some of the things we've been doing over the last couple of years in terms of supply of oral contraceptives via pharmacies, via community pharmacies, and also to talk a bit about the expanded role of the pharmacist in terms of moving forward in the increase of prescribing prescription-only medicines independently. So I think everybody's kind of aware, I imagine, that in the UK we have a different healthcare system called the NHS, National Health System. And within that, it's basically funded mainly through taxation directly by adults who obviously pay tax. And we also have something called a national insurance contribution. And that kind of covers you for most care you would expect. And most of that care is directed through the funnel of what you would call a family doctor, we would call a general practitioner, a GP. So just to give you some background to what it sits within. So back in 2023, the NHS created a new service called the Pharmacy Contraceptive Service, and to be embedded in all community pharmacies across the country. The government kind of identified that community pharmacies, as we know, really accessible, really convenient, and Mollie's point around the closeness of community pharmacies to any type of population is really the same in the UK. So the best place for people to access care. And also it was identified that we needed to improve sexual health services within communities, particularly in communities of inequity. And we needed to shift some of the load from our family doctors across to the wider healthcare team. Melissa, I just want to check you guys can hear me okay? Is that all right? Great. My Wi-Fi is a bit up and down, so I'll come off screen if it's not good. Just let me know. And so we commence this new service, pharmacy contraception service. The way that it basically works is a confidential service. It can be accessed either directly, so people can just come in off the street and approach the pharmacist, or they can be referred from their family doctor directly for it. And there are two functions. So one is people can be initiated on oral contraceptives for the first time, or if you've already been receiving it from your family doctor, you can just transfer your care over directly to the pharmacist. And it basically has allowed a wider choice for people who want to engage with those services. It's allowed better access, and also you get to do a bit of wraparound care. So signposting people to sexual health services, and also to do some safeguarding around the kinds of people who are maybe accessing help in that way. So it's allowed the pharmacist to kind of expand their role to do that. In terms of setting up to do it, the government made small grants available to pharmacies to set up to provide the service. And they went quite heavy with a lot of advertising material, whether that's on the TV, on radio, on posters, etc., engagement. They also did a lot of engagement and gave a lot of resources to pharmacies to talk to their local family doctors to make them aware that now we have this service and we're pharmacists and we can do this. And also for local sexual health clinics to be able to say, actually, the pharmacies down the road, if you're not open and able to provide services, we can. And a lot of pharmacies in the UK are open very long hours. Some are even open 12 hours. So the idea that actually maybe when you're closed, we can still help and provide that service. So a lot of investment was put into that engagement of stakeholders. And I think that is starting to make the change in people accessing it. Patients can access it if they wish. We either do combined oral contraceptive pills or progesterone-only pills. And there's a whole sequence of questions you go through and to determine whether which is the right choice for the person accessing the service. As part of it, we also do a screen for hypertension. So we would do a blood pressure check, height and weight to calculate BMI. So it's almost like a bit of holistic care that the pharmacist can be involved in doing. In the UK, people accessing contraceptive services, you don't have to pay for it. It's free on prescription. So the service, even though now it's provided within the community pharmacy, it's free at the point of access. So that has also been, I think, a major factor in uptake that we've seen. And it takes away like a big barrier. So hearing your barriers about claiming an insurance, I'm like, wow, we're very lucky. We still have to go through.
Louise, just letting you know you froze and you might want to turn your camera off. We'll give her a second. We're going to go silent for a second while I chat with her, and we can all be jealous and ponder the free services. Hi, Louise. I see you're back. Oh, we can hear you.
I'm back. I'm so sorry.
No, it's fine.
That's great.
We just wanted to let you know you froze. You were right. You froze right in the moment you were talking about feeling so lucky that you didn't have many of our payment barriers that you heard about.
Yeah. Yeah, so the pharmacists themselves still have to complete paperwork to ensure that they get reimbursed for the medicines they've given out, and they also get a small amount for the fee of delivering the service. But from the patient perspective, they don't have to pay for any of it. It's all provided under the National Health Service, under the NHS, which is kind of great, really. The services are available for people over the age of 16. But we do have guidelines about if somebody approaches and they appear to be under that age. So we have guidelines around assessing whether that person is competent to make the decision about accessing that treatment. So that is a bit of an ethical dilemma that some pharmacists are having to face and to navigate. Other things I suppose to mention, to try to what would I say, to try to organise the service and also to ensure quality, we have a national service specification, which basically outlines exactly what you need to do when you're approached to deliver the service. And also we had training, national training for people to do, both the pharmacists and the pharmacy team. So again, that made sure that we had quality in hopefully in what we were doing with that. And I think that's pretty much it about this prescription service. Hopefully that's a little bit of a difference to what we're doing here. In terms of, I was also asked to talk about the pharmacy first service. So we're seeing this move over the last few years of pharmacists doing more within a community pharmacy. Mollie spoke about pharmacists doing vaccinations for flu. We now have a whole host of vaccinations that pharmacists offer just part of their day-to-day work, for instance. But last year, almost a year to the day, 31st of January 2024, we started with the pharmacy first service. The idea of this is that patients could either walk in off the street or be signposted through other NHS methods to get advice, counselling and medication where clinically appropriate for 7 key conditions. And these included conditions for children, which is a big change from what we've had in the past. So the conditions are basically sinusitis, sore throat, acute otitis media, which is an ear infection, infected insect bites, impetigo, which is bacterial skin infection, shingles, and uncomplicated urinary tract infections. So 7 key areas there. And essentially, people could walk in, access the service. The pharmacist would take them through the process. So we had a national service specification. It involved some clinical, some clinical assessment. So for instance, for the otitis media, our pharmacists had to learn to use an otoscope to look inside patients' ears to determine and actually make a diagnosis. And then essentially, usually then to supply the medication. Again, because this is an NHS service, patients would either pay the standard NHS fee, so that they would have paid if they got it on prescription. The medication for children under the age of 16, patients don't pay for their medication. So that would again be supplied free. So that really is helping us really address sort of, again, health inequalities for people who struggle to pay for care. We had a lot of resources, a lot of stakeholder engagement, a lot of videos on Instagram, social media, etc. And it was hard because your point at the beginning of like, how much do you advertise when pharmacies aren't quite ready to deliver was a hard one. January, February last year was difficult for community pharmacies, but people are energized to want to do it. And the new pharmacists coming out are so excited to be delivering this type of care. So that's just I know you want to have time for questions, so I think I'll probably stop there. But yeah, just to sort of give you an overview of those 2 types of services that we're offering. Thanks, Melissa.
Thank you so much. That was so informative, and I love hearing about different and sometimes better models and underscoring the free part. Thank you so much, Louise. So There's so much information here, and I have so many questions I want to ask you all, but we only have about 10 minutes left, so I'm probably gonna focus it to two. I also want to say, folks, we probably won't have time to get two questions from the chat, but want to amend. I forgot we were in chat form and not Q&A. If you do have a question, please do drop it into the chat. Even if we don't get to them, I'll try to see they're addressed in some way, or maybe the speakers can address them later on if you contact them directly. But for now, just want to hear, and not everyone has to answer this, so only if you feel passionately you want to. I want to underscore, a lot of you touched on this, but I want to kind of underscore your best ideas here on how those working on pharmacist prescribing and those working to make reproductive healthcare access available without a prescription, how can everyone work best together to increase awareness of and demand for reproductive health services in pharmacies, whether it's underlining some of the things that worked best in your campaign or things you'd like to see going forward. Anyone want to dive into that? Somebody's got to dive.
I'm happy.
Go
I'm
for it,
happy to.
Victoria.
I'm happy to start.
Yeah. Thanks.
So it's really so a couple of things. One, it's interesting that we're all saying this chicken and egg thing, which is a challenge. It was also in my talking points for this. But I think one of the really interesting things that we could do together and we could collaborate on is potentially like studying the impact of this and testing different models and seeing, how can, potentially we learn from pharmacists prescribing models to do it without a prescription. What can we learn and gain from that? And then how can we test and measure the impact, maybe comparing different models and seeing the impact for not only pharmacists and how the process works for them and how seamless it is for pharmacists that are really busy and dealing with a lot of different care needs, but also the experience on the consumer's end and what it looks like through these different models. So I think also the variety from state to state is really useful for learning. We convene state advocates to help them share different learning. So what can we learn from North Carolina? What can we learn from Maryland? What are the different states' landscapes that we can begin sharing resources and information about how to implement this? So I'm really excited to, be introduced to so many people working on different aspects of this the system that we're all trying to work to improve.
Thanks, Victoria. Does anyone else want to lift up, something from their experience of having folks kind of view it as a whole, or even I'll expand it even beyond contraceptive services, the opportunities it presents for getting other kind of services at pharmacies as well. Louise, go for it, Louise. Oh, you might want to turn your camera off again though, because you're a little.
To make
There we go.
a call out really for looking for young people. I just wanted to make a call out for work for the new and the different. So looking at what we can invest in terms of pharmacy education, getting them understanding the importance of these kind of services, building their confidence in terms of consultation skills and helping them to be advocates for this and working with your local schools of pharmacy. That can also be a great way to do that.
That's excellent. Thank you. Mollie, maybe a particular follow-up question for you in this vein. Well, I guess to Jill as well. So many of the materials and things you did it felt like to sort of approach pharmacies with this sort of more holistic look in mind, even though you were focused on pharmacist prescribing. I'm curious to hear, more about sort of attitudes and willingness. Are people sort of seeing it as an opportunity moment to do more? Some people might assume, oh, people here, there's more things we can do. That's too much. And others would say, that's like increasing the amount of services that we can provide. Just curious if you could share a little bit more about sort of the reaction you were getting as you were starting to move county by county and now expanding.
That's a great question. And As we think about our future workforce of pharmacists, our pharmacy students are very excited about the opportunity to provide contraception services. And so they've been very eager to participate in the training and to learn more and to go out on their rotations and to participate in these clinical pharmacy services. Our early adopters were primarily independent pharmacies that were those small businesses owned in local rural communities. We were excited to have some chain pharmacies join on fairly early in the process as well. And we also have found that some of the support that pharmacists have needed has been just the logistics of incorporating it into their workflow. How do we schedule appointments? How do we bill for the appointment? And so our state association has developed a really nice toolkit to help support pharmacists around here's educational materials, here's the forms that you need that Louise was talking about to screen patients to assure that they are appropriate candidates, particularly for estrogen-containing products. We've also provided support in terms of how to do referrals to other healthcare professionals, and just seeing what kind of barriers that people are encountering as they're out in real life practice. Because it's one thing to dream up an initiative, it's another to actually make it come to life. And so we're really learning more about what kind of support that pharmacists need. And we're learning that, our early adopters jumped in to do this right away. They were very excited. They were very engaged. Now we're having, more and more people come on board to provide the service. And then we've had some who've said, I don't think this is the right business model for me, or I don't feel like that it's something I want to do at this point in time. And that's totally fine. We have specifically asked some pharmacies to walk alongside us, particularly for those counties where we had gaps in care. So we have approached certain chain pharmacies to say, we don't have anyone in this county. Would you be willing to provide the service? And we have found that those collaborative, trusting relationships that we have developed throughout this entire process with pharmacies and other reproductive health stakeholders, folks are willing to do that when we ask specifically.
I'd like to just echo what Mollie just said, which was Mollie jokes sometimes, but it's the truth that she feels like the secret sauce to what happened in North Carolina was really the building of relationships between not just pharmacists, but lots of other health professionals. So, for instance, our advisory committee has many people on it from the reproductive health world, providers, advocates. It has people in the pharmacy space. It has people in other nonprofit spaces. We've had roundtables with people from behavioral health, from community organizations. And so I just think it's really, sometimes in North Carolina, the OBGYN Society is very pro over-the-counter all birth control. And so, so it's been a real opportunity to offer the professionals these relationships as well, which, if you have a relationship with a pharmacist, yes, the birth control thing is great, but it also helps with your patients with diabetes. So that community building has been amazing. And the summit she showed you was an example of that. And I think that's also been advantageous for the people participating in this work.
That's fabulous. That anticipated my last question, which is, ways that folks who might be listening to learn lessons from all of you could think about creative ways to leverage those partnerships. So I appreciate you answering that in advance, Jill. Are there any last thoughts people want to share about partnership, experiences with integrating over-the-counter options now with pharmacist prescribing? Any last words of wisdom you'd like to leave others trying to do this work in other places? I like to leave folks with one last positive thought, if anyone has them.
I think I'd just say, really encourage folks to work in partnership with community-based organizations, communities that are actually, trying to access birth control and experiencing barriers, and just a special plug for, working with young people who we know face unique barriers to access. And they've played such a core leadership role in our coalition, and are, I think, one of the main reasons why we didn't get an age restriction for Opill. And they can be real valuable advocates and experts in this work. And so whenever you can partner with someone young, encourage folks to do that.
Thank you
To
so
that
much,
point,
Victoria.
I
Oh, go
think
ahead, Jill.
yeah, I was going to echo that too. Like, we've been so lucky to work with UNC, but the pharmacy students, I mean, they have been amazing. They have come to, I think, almost every one of our advisory meetings and presented. Like, they're very forward, and they've been given, and Mollie can say a little bit more, that's a lot of opportunity to not just incorporate this into their education, but to lead some of the future research and advocacy about this in the state. So I completely agree with Victoria. It's been an absolute pleasure to partner with an academic institution and have that experience.
It's wonderful. Well, thank you so much, everyone, for all of your wisdom, for leaving us with some feelings of hope. Louise, thank you for doing this at a big time difference and sharing your knowledge. Thanks also for answering Kelly's question in the chat about the OTC experience in the UK. I just really want to appreciate everyone who came to listen and to learn. You will see more from us. We are having one more of these on this topic on March 3rd. The very important, sexy issues of insurance coverage, billing, and reimbursement. But as you heard, that is kind of the crux of the issue, for better or worse, at least here in the US. So come sign up to listen to that, and really appreciate everyone's time. I hope you have a wonderful, safe, and lovely rest of your day. Take care.